Zoll technology will guide you to meet the 2015 CPR guidelines. High-quality resuscitation on the move is achievable, and high-perfusion CPR is within reach. When it comes to helping you deliver high-quality CPR, no one offers you more than Zoll.
So I actually retitled the talk without permission slightly to raise the question as to whether children might be small adults in the context of BLS, just to be a little more provocative. So these are my disclosures. I think we've already outlined them. The bottom line is I have no significant financial or intellectual conflict to declare, which puts me in the town of Dull in northern Scotland. I do participate in ILCOR. These are the ILCOR membership organisations. That group has done a tremendous amount of work, as you've all heard over the last day, and you'll hear more about tomorrow. And we've just recently published the most recent Science and Treatment consensus recommendations. Culmination of 5 years of work with recommendations. When we look at the Paediatric Task Force, we actually completed 21 PICO format questions. There were 5 pre-arrest, 3 CPR, 7 advanced life support, 6 post-arrest care. Oh, it's not coming up. Sorry, I am clicking on the machine, but it's... Okay. Thank you for pointing that out. I'm going to be focusing on BLS because I know that Professor Nadkarni is following on behind with ALS, and we had a limited number of questions which actually directly addressed BLS on this occasion. This is a list of the various questions. You can see we looked quite a lot at prevention of arrest. For BLS and CPR, we focused on compression depth, chest compression versus conventional CPR, and the sequence of CAB versus ABC, and I will talk a little bit about those things. And then we followed on with considerable amount of ALS and post-ROSC care. These are published, and of course you can look at them in both circulation and resuscitation. It's important to recognise that there's a reason why ILCOR hands off this material to regional councils for guideline development, and that's because our resuscitation guidelines, as they're delivered to our training programs and clinical practitioners, are not truly purely scientific. The science is really important, and it's important that science is done well and done in a transparent and non-conflicted way. But we work in environments where training and regulatory requirements, scope of practice, and our health workforce can be very different. Availability of resources can be very different. And we do need to interpret these in our own environment. We've just published the ANSCOR Pediatric Guidelines, and you find around the world there are numerous of these have just come out. But moving on, those guidelines do refer to age groups. And they refer to infants up to a year of age, and they refer to children who are defined for resuscitation purposes as from 1 to 8 years of age. Childhood's quite a cultural construct. If you are working in North America, children are seen in paediatric services up to their mid-20s. In our hospital, children are up to 15 years of age unless they happen to have a chronic condition or major disability, in which case they might be with us until they're 30 because there are no appropriate services to transition them to. However, we do try and keep things simple, and despite that, we still have different guidelines for basic life support between adult CPR and child CPR. Infants and children are the same, so there's only 2 things there. But for the newborn, we do have a totally different group. Now, I think newborn babies are truly alien in their physiology. They're totally different to you or I. I have much more in common with a 3-week-old baby's physiology than I do with a newborn baby's physiology who still has transitional circulation, different hemoglobin to me, and different biology in many ways to me. So the newborn group really do need to do things differently. There's some very sound reasons for them needing to do things differently. But do we need to do things differently between children and adults? If you're trying to work out if somebody is a child or an adult, often the best thing to do is to look at them and to make a judgment call based on their behaviour and their general appearance. So if I saw this person in my emergency department, I'd say this is a child. The other thing, of course, is that children, I'd like to emphasise, can be very effective resuscitation providers. And particularly if we train children early, they are more likely to intervene and more likely to be willing to provide bystander CPR, in fact, than those we try and train at my age. We found in previous presentations, I think, the effectiveness of the production of requirements for first aid and CPR training in schools. We don't have that in New Zealand. This slide came from the UK. I think, Jerry, you mentioned you hadn't quite achieved that in the UK. I saw this was in the news when I was giving another talk about 6 months ago, so I was anticipating it might be the case, but not quite there yet. Children have obvious differences in their abilities, psychology, how we communicate with them, their language, their age and development, their susceptibility to different disease processes, and that includes the reasons why they might have a cardiorespiratory arrest, different patterns of injury, which affects our approach to trauma, their outcomes, their rehabilitation potential, the return in terms of if you do get a good quality survivor from a cardiac arrest in a child, if you get good neurologic outcome, there's a tremendous return on that in terms of that person's potential over a very long period of time. And of course, as health practitioners, the size difference creates a lot of challenges with drug, energy dosing, equipment sizes, being familiar with multiple different approaches. But I'm talking BLS, so a lot of that stuff might not be so relevant in terms of the drug and energy dosing. If we look at CPR, the recommendations for the rate and depth of compression are surprisingly similar between children and adults. Both the child and adult groups talk about a depth of 4 to 5 centimetres, a rate of between 100 and 120, and the hand position is basically in the centre of the chest. We both say it's important to allow full recoil, minimise interruptions. And in fact, although we teach a 15:2 ratio in paediatric settings, there's actually, to my knowledge, no evidence that it's any better or worse than 30:2. The reason for sticking with the 15:2 in children is that over a 1 minute period, that's going to give you about 12 to 15 breaths. If you follow the 30:2, that's going to give you about 6 to 8 breaths. Paediatricians, as an expert group, believe that more ventilations are necessary. We don't know if that's actually the case in the context of a full cardiorespiratory arrest. We do know there's a tendency to overventilate in arrest settings. We do know that overventilation is bad. We don't know actually how much ventilation you need at different ages if you've got a collapsed circulation and you're receiving cardiac compressions. So actually this is an opinion-based statement that we stick with 15:2 in kids, not 30:2. In fact, at the time that the guidelines were revised from to go to 30:2 in adults based on evidence around the coronary perfusion collapsing as soon as you took your hands off the chest, paediatricians thought we were being very brave going from 5:2 to 15:2, where at the same stage the adult recommendations went from 15:2 to 30:2. So we kind of moved up in parallel, but there might have been an opportunity lost there. But the net result of what we know about CPR is that there's probably more to be gained by the focus on the actual quality of what's done in terms of adequate depth, adequate speed, full recoil, minimising interruptions than there is in which particular algorithm you choose. And that's reflected in having universal algorithms for people who are trained at the more basic levels and restricting our paediatric specificity to people who have a lot of responsibility for children in the health system and therefore undergo more specific paediatric training. Questions about compression-only CPR versus ventilation and compressions are different, however. Questions that are raised are interruptions for ventilations in that setting harmful? Do they result in a decreased bystander willingness to act? And we know that bystander CPR is something that we're trying to improve. And, do we get reduced outcomes because of that drop in perfusion pressure in children? Graham Nicol recently published in New England Journal, along with a lot of collaborators, a very large resuscitation outcomes trial. It's worth having a look at. This was cluster randomised, multiple thousands of patients. They had some groups of EMS providers providing continuous chest compressions, and we had some other groups of EMS providers providing compressions with pause for ventilation. It basically indicated in that study that there actually was not a significantly higher survival rate or more favourable neurologic function if you perform the continuous chest compressions. In children, we've had for some time now, in fact this was incorporated in the last round of ILCOR reviews, the Japanese registry data, which looked at, again, quite a large group of children aged up to 17 years of age with out-of-hospital cardiac arrest, and grouping them by age, grouping them by a presumptive cause of arrest as a sudden drop, as in cardiac type or more decompensating type arrest, and the presence and type of CPR by bystander, whether there was any bystander CPR at all, whether that CPR was compression only or whether that was ventilations and compressions. And they looked at favourable neurologic outcome at a month. The bottom line was that, firstly, CPR improved survival. The survival wasn't great anyway. We're looking at rates of 4.5% versus 1.9%. However, if you compared the compression-only CPR with no bystander CPR at all, the result was basically equivalent. So if you wanted the enhanced survival, you actually have to do the full CPR for children in that out-of-hospital setting. There was a slight difference if you separated out the presumptive causes being cardiac, but in most out-of-hospital paediatric arrest settings, I don't think you can tell the difference as a layperson bystander CPR provider. So CPR versus no CPR, 5% survival versus only 1.5%. Conventional CPR, in other words including ventilation, versus compression only, 7% roughly versus 1.6. And in fact, that 1.6 is not significantly different to no CPR at all. So I think the other thing to bear in mind when you're looking at this stuff is you do need to take out the kids who are less than 1 year of age. In many systems, the EMS services are not allowed to declare the person dead or the child dead at the time, and so you may have a lot of SUDI or truly dead infants included in that data set, and so that tends to contaminate your outcomes with a lot of non-survivors who were really truly dead by the time any response was provided. So we know compression-only CPR appears adequate for sudden witnessed arrest in adults. It may improve bystander CPR rates, which would be crucial for improving adult survival rates. However, for children with out-of-hospital cardiac arrest, there is significantly better survival with full CPR rather than compression-only CPR. And in fact, I think as a health professional, if you know that, I think the words willing and able start to lose their relevance. If you're a health professional and you have an ethical duty to respond to a child in cardiac arrest, and you know that compression-only CPR is ineffective in children, I don't think it's a willing and able question anymore. It's a question of whether you're willing to provide an effective intervention or not. The effective intervention is full CPR. Now, defibrillation, I'm not going to talk a lot about manual defibrillation because that's straying into venous territory, but AEDs are very much part of basic life support. We're trying to get them into the hands of lay people in the public access defibrillation programs. And it's relevant to consider energy settings because that links into whether or not it's safe or appropriate to use unmodified AEDs in children. We don't in fact know what the best defibrillation energy is for children. There's not actually a linear relationship between the weight or the age of the child and the energy or the effectiveness of the energy delivered to the heart in a child when you're using a joules per kilo dial on the machine. And in fact, from what we know about body mass and conductance and things, there isn't actually any reason to expect that there would be a linear relationship between 2 joules per kilo and the effectiveness of the shock. You probably need if you're really going to dose adjust in children along the lines of pharmacokinetics, you probably need a much more complicated logarithmic style dose adjustment protocol, which is not something that any of us, I think, can do on the fly with the defibrillator in front of us. All we know is that from observational registry data that 2 to 4 joules seems effective. We've chosen in Australasia the number of 4 joules per kilo as being easy to remember and just chosen 1. It does seem safe and effective to use unmodified AEDs in children down to a year of age. Now, we'd still prefer that if you have an energy step-down device that you use that, but if most people out of hospital cardiac arrest, there's going to be an AED. It's just going to be an AED that delivers a standard setting, and you're much better off to use that than not to use it. What we've done in the latest round is that we've actually gone a step beyond and said in the Australian-New Zealand guidelines, we've taken out that lower boundary of 1 year. We actually think that there's no reason not to put an AED on a collapsed infant or child at any age and follow the advice of that AED in the community. So that is possibly a point of difference with other councils around the world, that we haven't taken that 1 year lower boundary. We do have anecdotes of children surviving adult-style shocks, but that's not real evidence. We should also remember that shockable rhythms do appear to occur in around 15% of paediatric cardiac out-of-hospital arrests. Now that might seem a small proportion, but if we do get rapid delivery of defibrillation to those children, they might produce some of our best survivors. And we're faced with very low survival in out-of-hospital cardiac arrest in children, and any incremental benefit we can get would be an advantage. So in fact, the defibrillation approach in children is actually no different in BLS than in adults. Cardiac arrest drugs, I'm going to intrude on venous territory here a little bit, only to say that it's unclear whether any drug improves long-term survival in paediatric arrest, and that the drugs should certainly not take priority over delivering the best quality CPR, ventilation and circulatory support that we can. It's not about the drugs. This is our algorithm, and this is for infants and children. Basically, we tried to move from that to something more approaching this, so keeping it as simple as we can. This is remarkably similar to the CPR algorithm in structure. It's quite easy to follow, and it will fix most of the problems in your life. This is the adult algorithm, and if I go rapidly back to the children, it's exactly the same. The only thing that's different is some dosage information about joules per kilo, plus this little box at the top, which is the breaths and compression that we talked about at the beginning. It's basically the same algorithm, apart from 2 to 15 versus 30 to 2. So, are children ever just small adults? I think sometimes for resuscitation training and practice, yes. I think those of us who are dealing with paediatrics all the time, or in fact, in the case of myself, almost universally paediatrics, so the last 2 full cardiac arrests I attended to were both out of hospital and both adults, something always to remember in your training. You're not actually going to cause a lot of harm, and you're likely to cause significant benefit if you just follow the universal algorithm. If that's what you've been trained to do, you're not actually trained specifically in paediatrics, you're not used to paediatrics, there's nothing that we can tell you that would say, following the CAB approach as per the adult algorithm, following 30 to 2, push hard, push fast, don't stop, find an AED and apply the AED. There's nothing we can tell you that says that is doing bad things or doing any worse than following a specific paediatric protocol. So, as a paediatrician, I'm standing up here telling you that sometimes children could just be small adults in this situation. Thank you.